Regarding the femoral fractures, let's say if I have a child with a 3 months age with a femoral shaft fractures. So 3 months age child having a fracture means that the patient is non-mobile, and in an immobile or non-ambulatory patient, any fracture would give a high suspicion of non-accidental injuries. I will go to A&E, assess the patient, take a pertinent history. My history would be towards the first is the injury and the mechanism, and second is to exclude the non-accidental injury mechanism. I will the factors which can point towards non-accidental injury is previous admissions, previous referral to social care, multiple and on examination multiple abrasions, fractures at different age, rib fracture, metaphyseal corner fractures. Regarding the treatment, these fractures, I will prefer to admit the patient. The management of these fractures at this age is conservative with application of pelvic harness. The pelvic harness is a flexion abduction dynamic orthosis where the hip is in flexion as well as avoiding adduction with straps which are anterior and posterior. For this age, any angulation I would accept it, but normally in an elder age, the cutoff is 20 to 30 degrees of anterior posterior angulation, 18 to 12 degrees of varus and valgus angulation, and 10 degrees of external rotation are acceptable. When I see the patient in A&E, take a pertinent history, exclude non-accidental injury, and treat the injury. I will prefer to admit this patient for the social purposes, apply pelvic harness and do X-ray in the pelvic harness. If the child is stable, I will discharge the patient and later on follow up weekly the child. I will continue with clinical assessment for further 4 weeks down the line and do X-ray after 4 weeks and discard pelvic harness once there is adequate callus. I don't need to do X-ray every week itself. I just need to assess the patient clinically and find out if he's pain-free. If the child is less than 18 months, then I can use a gallows traction for 2 weeks down the line and then apply a spica cast. For a gallows traction, the child weight should be less than 15 kg. There should be no skin injury or vascular compromise itself. The traction, when used, the buttocks should be 2 to 3 centimeter clear from the ground, from the bed. The gallows traction is overhead traction where the skin traction is applied, and the traction is applied while the limbs are slight abducted and in extended knee position. If gallows traction is applied in a child of more than 15 kg, there is more risk of skin damage, vascular compromise, and a peroneal nerve injury itself. If a child of 1 to 6 years comes up with a but less than 25 kg of weight, I would prefer to do a hip spica cast. Acceptable angulation would be similarly 18 to 22 degrees of anterior posterior angulation, 8 to 16 degrees of varus or valgus angulation, less than 2 centimeter of shortening, and 10 degrees of rotation. The spica cast is placed in a humane position. That is, the hip is in 9-degree flexion. The elbow, the knees are in 9 degree of flexion. There is abduction of 50 degrees and 15 degree of external rotation, with a broomstick being applied. I would assess the patient and do a follow bi-weekly, every 2 weeks to assess the fracture configuration. The if spica can be discarded at 4 to 6 weeks time and do an X-ray. Anyhow, if 1 to 6 years child and the fracture is length unstable, I would prefer to give a duration of skin traction itself, which should be a parallel traction like a buck traction. While applying a buck traction, I need to make sure that when I'm putting crab bandage, they should be circular and extending 50% of the width of each of the bandage. If they are in a crisscross configuration, there is more chance of vascular compromise itself. If a child comes with a age of 4 to 12 years of age and a weight of less than 50 kgs, and here I classify the fractures in two types. One is a length stable fracture, and second is a length unstable fracture. In length stable fracture, these are basically amenable for flexible intramedullary nails. Flexible intramedullary nails we prefer as a stainless steel instead of titanium because it increases the chance of union. The flexible nail entry point is anterior and medial and lateral aspect 2 centimeter to 3 centimeter above at the supracranial ridge. The nails are produced both together while crossing the fracture side. I will use the F tool to reduce the fracture itself. When I am pushing the nail, I would like to avoid twisting more than 180 degrees to avoid corkscrew phenomena. The principles is nearly as fracture principles of a Charnley 3-point fixation. So there will be a fixation distally, proximally, and at the fracture site. My nail size would depend on the femoral canal diameter, and a single nail should be 33 to 40% of the canal should be filled. My goal with 2 nails would be more than 80% of canal filling. I would prefer to use these nails and keep the nails for at least 2 to 4 months until I have a very good union achieved. There are problems with these nails. When you are doing a supracondylar approach, these nails can penetrate in the neck region itself, and there is a chance that if you use this in a length unstable fractures, it can go into non-union. If there is a length unstable fracture, I would prefer to plate the fracture, as the flexible nails would be difficult to do and would have high risk of going towards non-union. I would not do a entry nail at this moment, but I would prefer to do it at more than 10 years of age or 11 years of age.